Hello and welcome to the topic Diabetes in Pregnancy in the module Obstetrics and Gynecology. By the end of this session, you should be able to define and discuss the types of diabetes in pregnancy, discuss the pathophysiology and risk factors of diabetes in pregnancy, list the common clinical presentation of diabetes in pregnancy, list the investigations needed for diagnosing diabetes in pregnancy, and finally, discuss the management and complications of diabetes in pregnancy. Let's get started. There are two types of diabetes in pregnancy which are pre-existing or established diabetes mellitus. It could be type 1 or type 2, and gestational diabetes. Gestational diabetes or GDM is a condition where there is carbohydrate intolerance resulting in hyperglycemia of variable severity with onset on first recognition during pregnancy. GDM usually presents late in the second or during the third trimester. The definition of GDM is used irrespective of the fact that the condition persists after pregnancy or not. Pregnancy is considered diabetogenic. There will be reduced insulin sensitivity due to the increased level of cortisol, human placental lactogen, estrogen and progesterone from the placenta. Insulin requirements are thus increased throughout pregnancy and are at maximal at term. This in turn may worsen established diabetes if not well controlled or cause gestational diabetes mellitus. The clinical presentation of diabetes mellitus in pregnancy may vary. Keep in mind that the classical triad of the symptoms of polydipsia, polyphagia, and polyuria may not always be presenting complaint by the patient. The patient may complain of extreme fatigue, blurred visions, and tingling sensation in the hands or feet. Patient may also present with previous history of medical complications of diabetes and obesity. So on physical examination, there may be presence of acanthosis nigricans. The symphyseal fundal height may be bigger than that of a period of gestation. In the case of established diabetes, bedside test involves a fundoscopy in order to look for any diabetic retinopathy. A urine dipstick is also done to look for any protein in the urine. Lab investigations include a fasting plasma glucose and the HbA1c levels to see the severity and monitor the control of the established diabetes. A renal profile is also done to assess any renal impairment that may suggest renal nephropathy. So let's look at the screening guideline. This algorithm shows the screening process for diabetes in pregnancy. So who gets screened? Women at risk of developing GDM as early as possible, and women at age 25 and more with no other risk factors at 24 to 28 weeks. A 75 grams load of oral glucose tolerance test is done, and if the fasting results are 5.1 and more, or 2-hour postprandial results are 7.8 and more, gestational diabetes is diagnosed. Overt diabetes mellitus is suspected in the presence of at least one of the following, where fasting plasma glucose is 7 or more millimoles per liter, or random plasma glucose is 11.1 millimoles per liter or more. However, the diagnosis of overt diabetes mellitus should be confirmed with a second fasting plasma glucose or random plasma glucose, or by doing another oral glucose tolerance test. If a patient with pre-existing diabetes would like to get pregnant, you would require to counsel her beforehand. It is important to ensure that her glycemic control is optimized before conception and her medications need to be reviewed. Consumption of folic acid should be encouraged at least 3 months prior to conception. For antenatal care, the patient needs to be managed by a multidisciplinary team with a diabetologist. It is important to ensure that she maintains a tight glycemic control. She should monitor her glucose at least 4 times a day. The frequency of self-monitoring should be individualized based on mode of treatment and glycemic control. Metformin should be continued in women who are already on treatment before pregnancy, and low-dose aspirin supplementation should be given from 12 weeks of gestation until term. HbA1c should be done every month to assess her control. Retinal assessment should be performed at booking and repeated at least once throughout the pregnancy, and renal assessment should be performed during booking. Those with pre-existing renal disease should be managed in a combined clinic. Lastly, ultrasound should be done at least 3 times throughout her pregnancy. Fetal echocardiography should be done at 20 to 24 weeks. Antenatal surveillance should be individualized. Here, a serial ultrasound can be done every 2 to 4 weeks to detect polyhydramnios, microsomia, or intrauterine growth restriction. When it comes to labor, the timing and mode of delivery should be individualized based on the estimated fetal weight and obstetric factors such as previous mode of delivery, gestation, antenatal complications, and of course the glycemic control. Some obstetricians may advise elective delivery by induction of labor. Women with no complications deliver between 37 and 38 plus 6 weeks, but if there are any maternal or fetal complications, delivery can be done before 37 weeks. In terms of mode of delivery, vaginal delivery is preferred unless contraindicated. Continuous electronic fetal monitoring is advised in labor, and consider elective C-section with antibiotics and thromboprophylaxis if there's macrosomia detected. Intrapartum glucose monitoring is done closely, and if targets are not achieved, infusion glucose is initiated. As for postpartum care, patients should be encouraged to breastfeed. Avoid oral hypoglycemic drugs if breastfeeding, such as metformin and insulin, are safe. Patients should be encouraged to breastfeed. Try to avoid oral hypoglycemic agents if breastfeeding. However, metformin and insulin are safe to be used in breastfeeding mothers. The baby requires early feeding and glucose monitoring as well. Complications may include recurrent urinary tract infections, increased retinopathy and nephropathy, preeclampsia, and operative deliveries. In terms of fetal complications, there might be a higher risk of miscarriages, congenital abnormalities, macrosomia, preterm labor, polyhydramnios, and intrauterine growth restrictions. Lastly, in neonates, they may be hypoglycemic, jaundiced, or polycythemic, and may have birth trauma, to name a few. Prior to discharge, make sure to check the patient's glucose level to exclude previously undiagnosed type 2 diabetes mellitus. 6 weeks postpartum, another oral glucose tolerance test should be done. Educate the patient about the risk of developing type 2 diabetes mellitus in the future, but this risk can be reduced by maintaining physical activity and avoiding obesity. In conclusion, diabetes in pregnancy complicates a pregnancy, but this can be minimized by the maintenance of a maternal glucose level as near normal as possible throughout her pregnancy. To recap, you should understand the group of patients who will require screening for diabetes in pregnancy, antepartum, intrapartum, and postpartum care in managing diabetes, and finally, post-discharge continuation of follow-up. We have come to the end of this session. Thank you.